Cartilage and bone form a functional and metabolic unit. Damage to the cartilage often creates progressive changes to the subchondral bone. This patient it has a trochlear 12 millimeter osteochondral defect with associated subchondral bone changes with bone edema and bone hypertrophy. This is the arthroscopic view showing the defect and measuring this in the medial and lateral and top to bottom dimensions. You can see that there is irregularity of the subchondral bone. This patient had a previous knee debridement approximately 5 years prior and is active in basketball. This is looking at the perpendicularity of the instrumentation for later repair. That's over a guide wire. Decision was made to use a dermal graft for augmentation of the repair. This is an acellular dermal graft that's 3 to 3.5 millimeters thick. We use a dermal punch to create a circular construct and then place a slit in the graft to allow the driver to come through the graft. You can see we're using the driver to hold the graft implant construct. The graft is fenestrated to allow marrow communication as well as a fixation point for sutures. These sutures are passed top to bottom from the graft side to the undersurface, and then an arthroscopic type knot pusher is used to fully seat the knots on the undersurface of the implant for secure fixation. In this case, 3 sets of sutures were placed. The sutures are trimmed appropriately, and then we have a cannulated driver for this implant graft construct. The countersink reamer is used. The flutes are used to ensure that you are 90 degrees from multiple viewing angles. There's contours of the top of the blades also to mimic the top surface of the implant, which is to be fully countersunk below the top layer of subchondral bone. The flutes are designed to cut and remove debris so as not to impact the bone to create a nice bleeding bed. The superficial layer of diseased bone, hypertrophic bone, is removed down to more healthy bleeding bone. And then, as you can see, it's over a guide wire. We're stopping intermittently to assess our depth. We will then measure the depth that's appropriate for the size of the implant, and in this case, using a graft augmentation. There is a second reamer, which is a coring reamer. Again, the flutes are designed to cut the bone and create a circular osteotomy for access of deeper marrow and to clear the bone efficiently as to not impact this. It's a bone preserving, subchondral bone preserving type technique, and allows the healthy marrow access to come up through the implant, which is a hollow type chambered implant. Here we can see the nice marrow contents. This is the graft implant construct coming down with the driver. This is over a guide wire as well, so it's guided. Each full turn is approximately 0.75 of a millimeter. It allows the surgeon to tailor the level of repair with respect to surrounding tissue. Typically, the aim is to be at least 0.5 millimeters countersunk with respect to any tissue to allow the graft to be a augmentation of this osteochondral tissue space. I'm using a probe here to palpate the surrounding tissue. This is the guide pin that remains, and you can see the slit within the graft where the driver entered the implant, and then a tamp is used to compress the graft, and in so doing, the slit is somewhat closed, and you can also use the tamp to palpate the surrounding tissue and to be assured that it is at the desired level of repair. The surrounding tissue can also be further debrided. This is a second look of a different patient that was a UPS driver. You can see the blood soaking up into the graft directly after the procedure. And at 2 years, there's nice remodeling of the graft with respect to surrounding tissue. His patient-reported outcome scores were excellent. The graft appears nice and smooth and firm. And the patient returned at this time for his opposite knee, which had a similar issue, and consented to this second look. And I'm using my probe directly over the reparative site. You can see how it's nicely filled in. This is a patient who had 2 implants in the trochlea, a college professor that is doing very well in the immediate postoperative period. We typically see no pushback from the joint, so to speak, in terms of activity-related swelling or pain, as the pain is typically from the bone. This is a CT arthrogram of a different patient. You can see there's nice continuity of the reparative tissue. Thank you very much.